I'm Laurie Heavey. I'm a Georgia HFMA Education Committee volunteer. Starting in June, we'll move the Wednesday webinar series to bi-monthly, meaning every other week for the cadence. But we are continuing with the weekly webinar series through the end of May. And if you're on the Georgia HFMA email list, you should be receiving invitations for other virtual activities. And specifically, we have some virtual networking events that are coming up, so please join us for those. If this is your first time joining us for a webinar, I encourage you to check the Georgia HFMA website to hear recordings from our previous sessions and also to get the presentations themselves. For today's session, we're pleased to have Linda Corley, Vice President of Compliance and Quality Assurance for Extend Healthcare. For those of you who have asked for webinars highlighting physician practices, this session is for you. Linda's topic focuses on payment challenges for clinic and physician offices. Before we get started, I'd like to review just a few housekeeping items. All of the phone lines are on mute to avoid interruptions during the session. Please be sure to submit your questions via the question box at any time, and I will coordinate with Linda for her answers at the end of the presentation. Right now, I am just about to post link. You'll see it in the webinar chat. That's a link to download Linda's presentation for today. And I've given you navigation to where you can find it on the Georgia HFMA website. This is also the location where we will have the recording for the session, and that'll be by the end of the week. Everyone on today's call is eligible to receive continuing education credits for participating. Please be on the lookout for your form in email. I'll be sending that also by the end of the week, and you'll be able to use that form to self-submit for your credit on the HFMA website under the Membership Info tab. Now it is my pleasure to introduce our speaker, Linda Corley. She has worked collaboratively with hospitals and physician offices for the past 25 years. In previous roles, Linda has served as controller of a university-owned 4-hospital group and provided insight to clinical and financial staff members on compliant reimbursement. Linda is a credentialed coder and a frequent HFMA speaker. She has over 15 years experience on the national level of leading CDM reviews, coding and billing audits, and has provided consulting services for revenue cycle improvement. And as I mentioned, Linda is currently Vice President of Compliance and Quality Assurance for Extend Healthcare. Linda, we're ready to begin.
Thank you, Laurie. Good afternoon, everyone. I appreciate your joining us this afternoon to talk about the collaboration of physicians and hospital team members working together. And my presentation does not speak to COVID-19, and I know that's what's on our minds as we meet today. But I think if you will look at some of these suggestions, they probably are even a little more important as we face the crisis that we're in than they are or they were before we started with this particular pandemic. So it is a lot of information, as I mentioned, regarding physician practices being purchased by hospitals or physicians being employed within the hospital or the health system. And I think this particular phenomenon, or what we've gone through the past 7 to 10 years with physicians and other providers becoming employees of the hospital, has given us a different environment. I also think that being cognitive of patient expectations in today's healthcare environment is very important. So we're going to start talking about payment, of course. As Laurie mentioned, if you have questions, please send them into the chat box, and we will have time to address those at the end of the meeting. As usual, I have lots of information, but I think that as we discuss some of the successes that we are seeing hospitals have with these particular issues, you will be encouraged to try some of these particular suggestions that I have. So as we look at today's healthcare environment, we know that pay for performance and value-based purchasing is extremely important. I'm still surprised when I see particularly hospitals losing reimbursement because of patient setting. So understanding whether our particular patient's medical condition meets the requirements for an inpatient For outpatient, I will add clinic patient into that category, or observation is extremely important. Of course, I also want to stress that payer specificity is very different from when I first began filing claims and being reimbursed. So we are going to talk about clinical outcomes that affect hospital reimbursement. I think quality is truly important. And when I'm working with some of our clients, hospitals and physicians, I do not hear quality addressed very often. So one of the perspectives that this particular presentation presents, or that I want to get across, is how important quality patient care, or those patient outcomes that are documented, that we can reflect on our claims, and that are a response from physicians and hospital team members or staff working together, are extremely important. So I say that patient care, those employees on the clinical side, and of course our revenue cycle team members on the financial side, must work together. I know when I first began working with hospitals a long time ago, we almost had silos for finance or revenue cycle, and I don't think we even called it revenue cycle at that time, but there was there was almost a wall built in between the clinical staff responsibilities and those individuals working within patient financial services, patient access, all of those areas that we know as revenue cycle today. I do think that there is an impact on clinic performance collaboration when we look at these reimbursement programs that we are operating within today, and we will talk about some of those. So this particular presentation, or these suggestions, are all about how you can prepare and actions that you can take for effective reimbursement that is going to be based on quality of patient care. According to CMS, of course, and we've heard this for some years now, the answer for rising patient care cost requires greater efficiency. And Medicare goes on to say, in the delivery of needed care by providers. Now, we all struggle, whether we're a physician practice, a specialty provider, a hospital, regardless of our particular entity type within healthcare, we struggle with medical necessity. But I do think at times we miss the fundamental component of medical necessity, which is our physicians understanding how medically needed care is going to be defined. Now we are looking at medical necessity guidelines that require medical outcomes expanded to address payment, and we'll talk about one of those. There are strong financial incentives within the marketplace for us as providers to slow our cost growth through improvements in productivity and efficiency. And I don't know about you, but I very rarely hear anyone, either in a physician practice or in a hospital, talk about efficiency, but we are going to stress that today. So we are looking for high quality care that meets the patient's immediate needs, which is our history, particularly in a hospital, but we also want to be able to address or meet those patient needs across a continuum of care. We don't want to just look at an episode of what that particular patient requires for his or her medical condition at the time, but how can we assist that patient through a continuum of care. All of the new reimbursement models, as you see there, that are utilized by CMS require hospital and physician collaboration. And collaboration is a good word to me. That means that the two perspectives, so to speak, the physician and what he or she is ordering for care, or a care plan for the patient, is being addressed specifically by the hospital. If we look at these reimbursement programs, you'll see there in our clinics, we may be provider-based, or we may be what's called a freestanding physician office, which is paid under the Medicare physician fee schedule. Certainly APCs have come a long way, and we are looking at numerous what's called a comprehensive APC or a bundled package of care for that particular patient, depending on his or her medical need. We'll talk just a little bit about oncology services later. Present on admission we will address, and then quality reporting is so important for your optimum Medicare payment. We'll also look at readmissions. But if you think about all of these different reimbursement or payment models, they all focus on meeting that patient's specific medical needs. And certainly today, we are also addressing patient expectations. So if we look at pay for performance as being a result of clinical outcomes, it always gets my attention that about 60% of cardiac caths may be unnecessary. Now, I think we also have to think about that collaboration of physician and hospital care, the clinical staff members that we have providing hospital care, when we look at some of these statistics regarding services that are going to be provided. I don't know about you, but I grew up in that era where even when I was working in a hospital, if a physician ordered a specific test or perhaps presented an inpatient order for a patient, we didn't question whether those services should be provided or not. But since, if you will think back to the Medicare recovery audit contractors, we found out very quickly that the hospital should be evaluating medical necessity and understanding patient care needs very separate from how the physician may see that particular patient's needs. So I think this collaboration, as I mentioned, and understanding that CMS has even told us in hospitals they may begin paying for cardiac caths on whether or not there is a primary finding of a cardiac problem related to that diagnostic cath. We want to be sure that we, for the hospital's component, are working with the physician to understand what is a medically necessary, not only cardiac cath, but cardiac procedure. And as you can see there, 37% of patients in this particular study, and it's a little bit old, had no blockages or no irregular heartbeat, abnormal findings from a lower level diagnostic test, or no history of heart disease. So understanding that particular patient's needs is going to play not only an important role in whether or not the services are being reimbursed, but whether or not we can continue to provide those services. And many of you know, of course, what has happened with Medicare, traditional Medicare outpatient laboratory tests. This slide reflects that 40% of repeat laboratory tests for the same patient on the same date of service already have current test results in the patient's medical record. Now, I, for one, thought that electronic medical records would assist with the care provider understanding this particular lab test has already been carried out either today or perhaps yesterday, sometime during the past week, and those results are still valid. Most often we see a problematic lab test when one is carried out as an outpatient, particularly in the ER, but then when that patient moves to the floor or moves to an inpatient category of service, those same lab tests may be repeated. And as I mentioned to you, currently Medicare is not paying for an outpatient laboratory test that's performed on the same day that other outpatient laboratory or other separately paid services are provided. Now, there are some lab tests that are being paid, but it's a very small number. And then we see that 40% of Medicare patient readmissions may be avoidable. And that one always gets my attention. I do see most of the hospitals with whom I am working have a penalty or have a portion of their Medicare reimbursement withheld because of patient readmissions. All of this means that we are changing our patient care paradigms. I mentioned immediate clinical or medical needs. Now we're looking at the ongoing or comprehensive needs of the patient. We always have focused on patient care needs, but now Medicare is even paying us for some work or some communication with the patient's family and other caregivers that's necessary. And I do think we've always been challenged by a variety of different care teams within the hospital environment, even when we are looking at our outpatient clinics, our outpatient physician offices. But now Medicare particularly, and even our private payers are asking us to address that continuum of care that I mentioned to you, a focus on the patient's medical experience over time. So here we are, and I'm going to give you a very short quiz for you to answer on patient outcomes. What 4 healthcare reform initiatives related to clinical patient care may be lowering your particular payments for this year? Most of these began way back in 2014. So if you are attending this particular discussion today, you probably already are addressing some of these, but it surprises me when I go into a hospital or even into a physician practice that is hospital owned, that we don't address these particular initiatives on a daily basis. I do see hospital physicians and other providers and the hospital care team as needing collaboration or having to work together to produce a positive effect on these reimbursement patterns that we're going to look at. And then I think not only should we be addressing short-term needs, but we need to be looking long-term as well. What initiatives or methodologies for payment should we be addressing on a monthly basis? And here I am out of the finance area or patient financial services, wanting to talk about patient care management. I don't think we can have a physician and hospital care team collaboration unless we focus on almost the person who builds that bridge in between physicians and our hospital clinical care teams, patient care management. And by that, we would be talking about case managers, utilization review team members, discharge planners, and that new important area of clinical documentation improvement. We'll talk just a little bit about that. So I'm asking you to think about your particular either physician practice or hospital outpatient area particularly, and rate your patient care management, these team members, on a scale of 1 being not so good and 5 being excellent. Because I think this evaluation of how are we performing as a team, physician providers, clinical care teams on the hospital side, how are we performing as a team together? You may want to think about 2 strengths of your patient care management team, or perhaps 2 weaknesses that you would want to address. And then I want to ask, how active are your physicians and other providers in this patient care management area? Have you provided education? Are you providing quality statistics to that patient care member so that he or she understands what's happening with patient care outcomes? And then if we look at what total dollar amount was written off, either for your physician practice, your outpatient clinic, maybe, as I mentioned, freestanding or provider-based, but what was written off last month, since we just finished up April, and even year to date, due to wrong setting, as I mentioned to you, we treated the patient as an inpatient, but he or she did not meet the payer requirements for inpatient care, not medically necessary, and unauthorized. And I truly don't have a silver bullet for authorizations, but I think that's an area that requires continued review, discussion, and an initiative or a methodology for approaching authorizations that does not leave you with dollars written off as uncollectible. This particular table shows you where we are for 2020, and these are the reimbursement programs that I was mentioning to you. These are Medicare, of course, but here we are with value-based purchasing. Medicare may withhold up to 2%, and this is not sequestration. I want to point that out before I forget, but Medicare may withhold up to 2% of our Medicare usual reimbursement for both inpatient and outpatient services if we are not reporting our quality indicators as required under value-based purchasing for Medicare patients. Hospital readmissions I mentioned to you, and look at that 3% additional that Medicare may be withholding. Hospital-acquired conditions, which we call present on admission. Also, the patient came into the hospital but developed an infection that was not present on admission. We may be losing 1% of our Medicare reimbursement. So as we look at 2020, we may be forfeiting, or Medicare may be withholding 6% of our entitled reimbursement based on our costs because of these particular pay for performance areas of patient care. And here is where I say clinical care affects payment. As I mentioned to you, the one department that I'm interested in strengthening, in making sure our procedures, our processes are well defined, they are written. We have shared all of our patient care management policies and procedures, not only with our physicians, but our clinical care teams. Anyone involved in providing patient care, I think is important for them to understand how patient management is going to become involved or should already be involved to make sure our clinical outcomes are what they should be. So I see case management, of course, involved in patient status, inpatient, outpatient, or observation. Utilization review, certainly in obtaining those authorizations that we need. Discharge planning. I see, and I used to have a statistic, but I see probably 7 out of 10 hospitals with whom I work keeping patients longer or a greater number of days than their DRG or MSDRG says is their approved length of stay. So if you are holding patients as inpatients longer than their medical condition warrants or the acuity of their medical condition, then of course you are losing money on those patients. Clinical documentation review, I mentioned to you, and I think we're back to documentation to prove patient acuity and the intensity or the level of service that that particular patient required. Extremely important, all of these 4 areas for reimbursement. And I think this has been a cultural change for some of us, just as I mentioned to you. I grew up in that time where if a physician wrote an inpatient order, we looked at that as, yes, this is the care the patient should receive. However, now I think we are charged with, on that clinical care patient side, to review and ensure we have an appropriate diagnosis, of course, but that our documentation meets the criteria for what a physician or other provider has ordered for that particular patient. Back in 2017, already 42% of hospitals reported that 30% or more of their particular revenue stemmed from value-based contracts. Now, think about the Medicare Advantage plans and traditional Medicare. Think about traditional Medicaid, as well as the Medicaid HMOs or CMOs in Georgia. And think about the percentage of your reimbursement that is based on these value contracts as far as clinical patient care outcomes. Another 22% in this particular study expected 50% or more of their reimbursement to be based on value-based contracts by the close of 2018. And now here's where I want to talk about what I have seen be successful for physician and hospital or even hospital system collaboration. And I've worked with about, I started to say 4, but I think 5 different hospital and physician groups over the past 2 years to come together to a collaborative approach towards patient care. And I start out, sometimes my Southern whatever creeps into my vocabulary. So I am of the opinion that I go into a lot of hospitals, I hear lip service for physician and hospital system or hospital clinical care teams working together, but I'm at the point that I don't think lip service will yield results that are needed. So sometimes what we start with in these meetings or these collaborative sessions is both hospital leadership and our physicians that now may be hospital employed, but in some cases are not, must agree that whatever has gone on in the past, we are going to start fresh or anew and reframe the reimbursement challenge to place patient, physician, and hospital interest all together. And notice what comes first: patient interests. We want to equalize each party's importance, but I do think we have new patient expectations that we need to be discussing with our physicians and our medical or our clinical care teams within the facility to be sure that we are addressing these challenges and meeting the different needs of each party. We really want a new vision, as how I see it. What does success mean for providers or physicians? What does success mean for the hospital reimbursement perspective? And then patients we want to place first, what does success mean to them? So we want to identify specific improvement through collaboration opportunities. And I guess I can't get away from that word collaboration, but it's important to me, working together to see what co-management opportunities of clinical and operational standards and procedures we can put in place. What areas should we be reviewing or discussing? Certainly quality of care. Technology is a big issue with our electronic medical records and now working on interoperability. So technology not only for hospital documentation of services, but understanding physician needs in that documentation, I think, is extremely important. Certainly financial. How will we continue to operate to provide the services that patient needs? And then, as I mentioned, either hospital-based clinics or our hospital outpatient departments that all depend on physician orders and interaction to provide patient care. I think governance is important. Who is going to make the difficult decisions when they are needed? Certainly research, because we have numerous hospitals that are involved in clinical trials, in providing new services for patients. And then I've included payer contracting, because I think understanding that communication with payers and knowing what we can fulfill in a payer contract and what will be difficult is extremely important. So to begin with, the hospitals that I have worked with and the physicians agree and adopt a very small number of initial projects. What do we see as our needs today? And I know all of us within healthcare are almost worn out with the different initiatives that we have adopted over the years. But I think this one is actually the daily operation and provision of patient care services almost on an hourly basis is what we're talking about. So while we are calling it an initiative, I think it has to be a method of operation that places these 3 parties that we're talking about patients, physicians and providers, and hospital medical care teams places them together in this effort to be successful. As I mentioned to you, we want to work on resolving past problems, agree on the goals going forward, establish some metrics that providers and hospital care team members have confidence in. And I am of the opinion, I'd be glad to hear from some of you, I think we have too much information. I think when we begin looking at, are we going to be successful meeting patient care needs, we need to look at a set, almost 4 or 5 metrics that will tell us for this particular department or clinic, are we going to be successful? How are we going to evaluate that? We do want to evaluate performance. Again, realign our procedures, our processes, those need to be in writing. And then we do want to reward accomplishments, even if it's an only, gosh, we did a good job with that. I think, understanding what has been accomplished and looking at that is extremely important. Once we tackle some of our smaller issues, then of course we can move on to projects or initiatives that have higher value and longer term goals. And that's why I mentioned to you both short term, what do we need to look at today in order to improve our patient care outcomes and our reimbursement? How can we put those together? And then what are we doing? Certainly under this COVID-19 pandemic, we are being challenged. But some of this, I think, can be used simply to address what we see as specific needs today as we address the care of these particular patients. Certainly hospital readmission, and I'm not going to read all of this to you. You might want to look back at it a little bit later. But the problem that we're having right now is that back in 2018, Medicare or CMS decided to add cohort diagnoses. I want to show you the penalty. That's what's on this slide, 3%. And of course, I mentioned to you it's not budget neutral. Hospitals can either maintain their full payment level under Medicare, or they may be subject to the penalty. And then the part that I want to mention to you are these cohort diagnoses that you see there: aspiration pneumonia and a principal diagnosis of either sepsis or respiratory failure, and a secondary diagnosis of pneumonia. If those are present on admission, then all of that is included in our hospital readmission determination factor. So by expanding the definition back in 2018, Medicare is actually looking at about 65% of the number of cases that fit into their review of a Medicare patient being readmitted. Why are patients readmitted? I always like to share this part because I have been involved in a couple of these reviews and have been working with some facilities on their readmission factors. 69% of patients were non-compliant with their medications. And I can tell you, it's always interesting to me, and you may have heard me say this before, but I have been on at least 3 different phone calls with a patient being called by a UR nurse to follow up on his or her inpatient admission. And when the nurse asked the patient specifically, are you taking your new dosage under the changed prescription that Dr. Smith gave you while you were an inpatient, that patient replies, no, I'm still taking my old medication because I have to take up what's in that bottle before I get my new script filled. And that, I think, is probably, nationwide. Patients see medication is expensive, and certainly because of some of the age of our patients, they feel like my health has to wait on making sure that I take up my old prescription before I move on to this new. And I'm seeing discharge instructions asking that patient, Will you be able to get this particular new script filled today and begin taking your medication as the physician has prescribed for you? 51% of patients lacked knowledge of how to use therapy devices, and that can either include inhalers, back braces, even over-the-door exercisers I've seen mentioned. 45% of our patients have an inadequate knowledge of even why the medication should be taken. And that's an important one to me that we can address with our outpatients and even during discharge planning. 42% are unable to self-manage their care. They may be experiencing increased symptoms or an exacerbation that is going untreated. And I'm going to tell you something that a couple of the hospitals I'm working with, what they are doing to address that. 37% of inpatients had no follow-up visit with their physician or admitting specialist, even though I know that for years we have been advising patients with those inpatient discharge orders to see their primary care provider. 31% did develop an infection. So think about all of these medical reasons why we may see a patient readmitted and how working through quality patient care and education, we may be able to address these particular readmission factors. So here is one example of patient-focused collaboration. I did work with a big health system back in January of 2017, and what they did was the hospital care team collaborated with primary care or specialty clinic to set that patient appointment within 3 days of the inpatient discharge. So in other words, the hospital care team reached out to the physician, particularly for these patients, diabetes, congestive heart failure, COPD, and any cardiac related problem. So the hospital care team, before that patient was discharged, set the patient appointment. Once the patient underwent or had their physician, the care provider appointment, that clinic visit became part of the physician EHR and was shared with the hospital UR team to validate patient care for ongoing stability. And I left out that if that patient appointment was set with the physician or the specialty care provider in an outpatient setting, the patient was actually called the day before the appointment to remind him or her, you have your appointment tomorrow. Do you have transportation? Is everything set for you to show up for your appointment? After that clinic or outpatient visit, the UR clinical care team telephoned the patient weekly to record patient progress, particularly in these areas that can exacerbate blood sugar, blood pressure, breathing difficulty, just a touch base. And I've been involved in some of these telephone calls, and generally they're only about 5 to 7 minutes. Someone of a clinical background checking in with that patient to say, how are you doing? Are your blood sugars within normal? Are you taking your insulin? Do you have any questions? Is there any medical need that we can help you with? So then the UR or the patient care clinical team member would communicate back with the clinic if another outpatient visit was warranted. So although this sounds like a lot of activity, they have gotten it down almost to a science. It's carried out very quickly. It is well supported with documentation in the patient's medical record. And this particular health system reduced readmissions by 37% in the initial 6 months that they worked on this. Now, 37% to me is considerable. That is a large percentage to say simply by having patient interaction, by bringing those patients in, let's say, not only for the initial outpatient visit, but for a subsequent visit, if their condition was destabilizing, that not only helps reimbursement, and as you all know, I'm a reimbursement person, but think about patient care, what it does for allowing that patient to maintain a stable health status over a number of weeks. And I think truly that's what's important. I'm back on patient access these days, and I have some slides at the end of this presentation that I'm not going to go through, but I still think we focus on patient access not only for our hospitals, but even for our physician practices. We stay very current with our patient registration, coordination of care kinds of questions, eligibility for certain insurance plan coverage. But I think this is back in the forefront to me. So I've included some slides at the end of the presentation. I'm not going to go over today, but if you have any questions, please email me or call me. I'll be glad to cover the slides with you and talk about. I think we simply have to know for any patient intake area, opportunity for improvement versus reality. We need to understand our strengths and weaknesses, and particularly, I know many of you have not been carrying out outpatient or same-day surgery, but I see large dollar amounts written off because we do not have good patient access policies and procedures in place that are followed consistently for outpatient and same-day surgery. I also wanted to mention ABNs to you, a difficult process again, but I do think understanding where, and because we are all so different, both physician offices and hospitals, we are very different, but I think incorporating patient care management into our ABN process, and we must have them for our inpatient, our HINN, hospital issued notice of non-coverage for inpatients, is extremely important. They are necessary to our quality of care because I am seeing, as I work with our hospitals, I am seeing more patients when they are told Medicare may not pay for this, just refusing to have the service. And of course, we want to work with that physician. We want to be sure if there is a diagnosis that meets medical necessity, that we've obtained that. But I also want to educate our physicians. And I say there at the bottom of the slide, hospitalists are great to focus not only on HINNs, inpatient, but also outpatient. So physician education should be our initial goal. ABN, registrar in the patient access department with a care management resource, a clinical resource. And then, as I mentioned, the patient care manager or case manager, UR nurse for inpatients, extremely important. And I think here is where patient responsibility becomes important. Incorporating patient care managers into our process for medical necessity improvement will also improve our relationship with our patients. I am seeing more and more patients, of course, have a larger patient responsibility percentage, and I'm also seeing more and more not have the care, as I mentioned to you, because of that financial obligation. I wanted to mention, just because I've been working with a hospital last week on outpatient surgery, revising some of their policies and procedures, please don't provide what I call bed and breakfast after outpatient surgery. Observation is non-covered by Medicare, and I'm finding that most commercial payers are no longer reimbursing observation after outpatient surgery. Medicare tells us that that outpatient procedure should be of a particular medical acuity so that the patient can be recovered within an appropriate number of hours and released from the hospital or discharged on the very same day that surgery is carried out. And I'll mention to you that most payers do not recognize vomiting, nausea, any of those symptoms as appropriate for observation care. That's not a complication, in other words. I also want to mention to you just quickly, chest pain unsubstantiated by some type of lab test findings like cardiac enzymes, an EKG, or a history of cardiac-related problems. We have given back millions of dollars to Medicare because we are admitting chest pain patients as inpatients, and unless we can verify a particular cardiac-related condition that is causing that chest pain, those patients should go into observation for at least the first 12 hours. Generally, after 12 hours of observation care, the physician, the provider, will know whether or not that particular patient has a cardiac-related condition. I do say that incorporation of process improvement by payer is important. I won't read all of this to you, of course, but just think about payer specificity. Extremely important. It's important to the patient that the care provided meet his or her insurance plan coverage requirements. And then, of course, we've talked about medical necessity. I will bring up to you the oncology center that I've worked with for a couple of years now, and they truly had a problem with patients being admitted after outpatient chemotherapy due to the adverse symptoms that patient would exhibit. The patient would stay overnight. Generally, they ended up with an inpatient order. However, primarily the patient was staying overnight because of that nausea or some type of symptom-related care plan or treatment that was needed. Of course, once those inpatient orders and supporting medical records were reviewed by the payer, the services did not meet inpatient criteria, so that oncology center was facing considerable write-offs. We did get the physicians, the oncologist, and the hospital care team together. They established 4 beds in the oncology center, which is an outpatient center, of course, for observation. The nurses received some additional training on monitoring, specifically chemo and even radiation therapy symptoms, and the physicians approved outpatient protocols for up to 18 hours of observation care. If the patient was unable to be discharged after that 17 and a half or 18 hours of observation, the patient was at that time reevaluated for inpatient admission and a new physician order. Now, keep in mind, for traditional Medicare patients, because we now have the Medicare to midnight rule, if that patient has received outpatient care over a midnight service time, and the physician does not feel the patient can be appropriately discharged, or I should use the word safely discharged, if the physician will document the patient's medical condition that prevents that safe discharge, then that patient can be upgraded to an inpatient because of that 2 midnight rule. So that is helpful not only for patient care and plan coverage, but also for reimbursement. The medical oncology center nurses and 2 nurses from the hospital UR team huddle each morning to discuss the patient's schedule for oncology and any medical problems from patient telephone calls or even the prior day's treatments. They may also involve UR in as a follow-up team to contact patients between appointments for what's just called a condition check, general medical stability and readiness for the next planned treatment. Now, simply having this limited number of beds, observation beds in the oncology center itself, with the nurses retrained just a little bit to understand how the protocols, care plans were going to work, this has improved patient satisfaction tremendously, allowed for a more controlled flow of patients and the care. The interaction with their patients either the day before their scheduled appointment or after they have experienced a problem has allowed that patient to receive the care needed in the particular status that's needed, and has made patients appreciate the care and be more satisfied in their patient care surveys. This new approach has met the physician's desire for quality patient care, and it's a plan in place. The oncologist does not have to be called back in or, give information at different times during the day because the care plan is there. This has improved reimbursement for all payers. So again, I think bringing our physicians, our care teams together, and simply understanding what is required allows for process or procedure improvement to meet the patient's quality care needs, to meet the physician or the provider's needs, and then to assist the hospital or other quality care team in how the services should be provided. I do think physicians and hospitals have to combine to form that management action plan that I've been talking about. You do want to be location specific. In other words, we can't make the plan for the hospital. We need individual outpatient physician offices or clinics or outpatient departments. And I do think talking about what is being achieved in a positive manner is important. I say constant and consistent analysis and adjustment of the plan is necessary. And there are lessons to be learned, of course. And each of the hospital systems that I have worked with in carrying out this process, there have been different lessons because I say that we all provide, all of us in physician offices and hospitals provide the same services, but somehow we do it just a little bit differently from location. I also want to mention one client has a 4-member, what they call their CLIN-FI team, clinical and financial members, 2 of each. They simply have the statistics or the metrics that are key performance indicators. They, spend 15 minutes with physicians on a quarterly basis, 30 minutes with the office care team or the front office staff. And all of this is very specific to the location in which they are in. So it's giving up-to-date information in a very brief but meaningful manner about specific denials, missed authorizations, updated coverage guidance. I think about Medicare and our updated quarterly bulletins that we receive. What are the documentation improvement opportunities? I have been so pleased with meeting with physicians, and when I have a limited amount of information, it's their information, and I can share it in a very almost bulleted manner. They are very receptive to, oh, okay, I understand what you're asking me. I do think patient concerns, complaints should be raised, but then a lot of times hospitals, physicians are receiving thanks from patients that we want to make sure that we pass on to all physicians and patient care teams. This particular hospital and physician system has seen a cash in the door increase of 22% in the first quarter, and I'm looking to see what they're going to maintain. The first quarter that they carried it out was the fourth quarter of 2019, so I'm interested in seeing what they've done for this quarter. This slide is all about what can you do or what will you do? How will your specific clinics, physician offices, or facility outpatient location positively affect these payment methodologies? And I think down at the bottom, including our physicians, our providers, in all discussions is what's so important. This is my management work group. I'll just show you the slide. Of course, you will have these. Here are the team members to include representatives from that I have found to be successful. And then here are some questions that I would give you to ask as you become or you lead this particular group for improvement. Here are the questions that would be top of my list. And I do think success is not only attainable, but it's extremely important that we get there. So I will stop, and I know I'm past time. Laurie, forgive me, but what kind of questions do we have?
That's okay. We're doing okay. So we still have 5 minutes left, and for those of you who can stay on with us after, that's great as well. So the first question here is really asking for some comments. Aren't some hospitals holding patients at times due to concern over possible readmission?
I see some of that, yes. But I, I, I'm just, I'm more in favor of understanding that patient's medical condition. Does our documentation, as I mentioned, meet the level of acuity? I know that we in hospitals, you know, talked very loud and long about our patients being sicker than ICD-9 gave us credit for. Well, now ICD-10 is very specific, but one problem with that is if we don't receive the appropriate documentation from the physician or the provider, we are going to end up with an ICD-10 code that is not as specific as we need for our optimum paying DRG. And I probably should have included just a little bit of that. But I think it's so important that we be transparent. I almost said truthful. If we are keeping patients additional days because we don't want them to be readmitted, then I would be digging into those medical records to see, do we have the correct principal diagnosis? Do we have any comorbid conditions that need to be coded to increase the level of the DRG, the MSDRG? Or do we understand how this patient's medical needs should have been treated? Now, I just had a conversation yesterday, believe it or not, and I'm way off the subject, but I had a conversation about how a patient was kept in as an inpatient from Friday until Tuesday because a particular specialist could not come to the hospital for a consult until Tuesday. Now, I would have evaluated that patient from a clinical standpoint to see could they be safely discharged, and if so, could the patient come back for that consult as an outpatient? Could the consult have been delivered by telehealth, which I've not mentioned to you today, which we are getting more and more used to using? But I just think we need that patient care management individual within the confines of those decisions being made. So good advice is being given to both patient and physician, and particularly decisions are being made appropriately for not only patient care, as I talked about, quality, but for reimbursement as well. And I'm not one of those people that I don't want to put reimbursement first in everything, but I certainly want it to be a close second, if that makes sense. I don't want to be paid for anything that we're not supposed to be paid for, but all of these patient care management decisions that are being made should take into consideration patient, physician or provider, and then the area, either physician office or hospital outpatient. How are we going to collaborate and have good outcomes for all? That was a long answer. I'm sorry.
That's okay. This one's another, probably, it's not really a question, but probably more just a comment, I guess. Consider adding coding to CDI, especially for sepsis. I don't see CDI providing physicians with payer reimbursement dependent on documentation meeting sepsis 3 criteria. Some payers are on 100% prepayment review for claims with sepsis as the principal diagnosis.
Absolutely, and thank you for making that comment. I completely agree. And see, I didn't go into that area of CDI, including coding and concurrent coding. I'm all for. Now that means when my patient comes in, after the physician has prepared his or her diagnosis, onset diagnosis and care plan, I like to have a coder involved with a care manager at that time to come up with a working principal diagnosis and DRG. And that way we know, oh, this is DRG 432. It has a length of stay of 4.2 days. So my clinical care team immediately begins working on having that patient meet his or her medical needs, but having that patient ready for discharge within that particular time frame of those average days. But I do agree, any way that we can include coding and clinical care team together is extremely important. We also probably should mention quickly that CDI team. A lot of times I need that clinical team to work with the physician because, and I'm not picking on coders, I'm a coder sometimes myself. Coders and physicians sometimes don't use the same terms. It can be exactly the same medical condition, but we may call it something differently. So having that clinical team member to help both with CDI and both with working with that physician on a concurrent diagnosis. And we also may find that if a coder is reviewing the record as the patient is in the facility as an inpatient, just simply a coding question to clarify what we call that query, of course, to clarify a comorbid condition or a particular diagnosis helps with both acuity and the intensity of the services we're providing, which both result in a higher paying DRG. So thank you for that information. That is excellent.
Okay, last question. Do you see value in incorporating social determinants of health benefits in the registration process to improve the patient experience? For example, offering patients local and state links to benefits and a plethora of help with utilities, transportation, rent, education, etc.
Yes, I completely do. And I did mention, but I should have that at readmissions also, CMS is looking at to make sure that if that patient has some social determinants that are negative, that where the hospital is located, the patient population being treated, but I think everything that we can include in our patient access process, or our patient intake, I guess is what I should call it. But absolutely, I think that continuum of care requires us to almost be involved with, is this patient going to be able to care for himself or herself? Is there a family? Some of the hospitals that I work with, does this patient even have a home to go to? All of those are important. And I think working our way into some of this patient interaction is what is going to help us be successful with the continuum of patient care, not just that episodic like we have done in the past. So I do agree. And I'm seeing more and more patient access screens ask for this information. And then even in outpatient discharge instructions, believe it or not, I'm seeing more and more links, as you mentioned, or other information that's being included to assist that patient with their medical care or whatever, particularly chronic illness they may have.
Okay,
I'm
great.
sorry, I'm so long-winded.
That's okay. Good information. That does conclude the questions that we have here. So just a reminder, everyone, before you hop off, our special Wednesday webinar series runs now through the end of May. Please be sure to join us at 1 p.m. Eastern each Wednesday. Next week's webinar is Engaging Patients and Addressing Their Financial Concerns from a Distance. Be on the lookout for our emails to register. You can also register via the events calendar on the Georgia HFMA website. And we'll also be publishing the slate of webinars for June and July very soon. Again, Linda, thank you so much for sharing all your expertise, lots of great information. And for all of you, please be sure to check the Georgia HFMA website to download Linda's presentation, including the slides she mentioned about access. Also, again, be on the lookout for the email from me with your CPE credit form, and you can use that to self-submit for your credit. Thank you, everybody, for joining us again today. Stay safe and have a great afternoon.
Thank you, Laurie, and thank you all for joining.
This concludes our session. Thanks, everyone.